Hello, my name is Dr. Felipe A. Jain. I'm a clinical instructor of psychiatry at UCLA and the developer of a meditation and guided imagery program for dementia caregivers. The subject of our talk today is how can meditation and mindfulness practices help family caregivers. You can join the conversation with us on Twitter. I will be responding to questions that are sent to the hashtag #UCLAMDChat. So first of all, let's talk a little bit about who you are, who the dementia caregivers are. As you know, and as many of us also know, dementia caregivers, particularly spouses, adult children of care recipients, provide a needed and valuable service both to the care recipient as well as to society. And they can save the healthcare system millions of dollars by doing so. For example, by continuing to have the dementia patient at home in their own environment, the environment that's familiar to them, where they know where everything is and they're surrounded by their familiar pictures. But also in terms of saving the country the costs of institutionalization, which do average into the 70 to 90,000 range per year at the present time. So it is a huge service to society. A consistent risk factor for institutionalization of Alzheimer's patients is psychological stress and depression of caregivers. This has been identified by multiple studies. There are many reasons that a dementia caregiver may develop these kinds of unfortunate complications. Dementia caregivers are at about a 50% risk of developing major depression. That's actually higher than the risk of depression in cancer caregivers and caregivers for other chronic severe disorders. There's something very particular about losing a family member along with their identity over the course of time that really strikes at the heart of the relationship experience. There is compromised immunity. There's been found to be more days of infectious illness that dementia caregivers experience due to the stress of caregiving, as well as disruptions in the actual cellular immune responses. When you do a blood draw, for example, on a dementia caregiver and expose that blood to antigens that would trigger an immune response, what you do find is that those immune cells are weaker. They don't mount as much of a response as non-caregivers. And there's even an increased risk of death. One study found that it was increased by as much as 63% over the course of 4 years, and particularly in caregivers reporting strain and stress pertaining to their caregiving experience, the day-to-day ins and outs of what they have to do for their relative. Interestingly, though, this risk of death was not increased in caregivers who did not report strain. So in those caregivers who were able to manage their role for whatever reason, perhaps their relative was not as sick, perhaps they had a higher innate resilience, perhaps they learned skills that helped them to cope. But if they did not report that they experienced subjective strain from their caregiving role, then they were not at increased risk of death. Clinically speaking, we often observe that the caregiver may die before the relative with dementia. And we think that is due to the increased stress on the caregiver, whereas the care recipient doesn't know what's going on a lot of the time. The caregiver is acutely aware of it in the ins and outs, and that does take a toll. How does this happen? How does caregiver strain lead to poor health outcomes? Well, there's a combination of factors, including the caregiver burden, so the number of hours per week, the kinds of tasks that the caregiver has to perform, anything from dressing the care recipient, to changing a diaper, to taking care of new roles, for example, doing the taxes, if that's been the care recipient's role, or managing the financial matters. There are the symptoms of the care recipient, which can be very disturbing, not only the memory loss, but sometimes aggression, particularly when the care recipient is in pain or has an infection, and also symptoms of suspicion, paranoia, hearing voices. These are all things that can evolve over time, over the course of dementia, which can result in caregiver stress. And finally, grief related to the relationship loss. When a person has lost a family member to the chronic course of dementia, that caregiver no longer receives the love in the relationship that was once present. The personality of the care recipient often changes, and that can be extremely difficult for the caregiver to cope with and to know how to respond to. So when the caregiver encounters a stressor of this nature, the caregiver evaluates the stressor, and this may occur consciously. So for example, the caregiver sees the care recipient do something and realizes, for example, let's say that the care recipient has gone to the bathroom in the wrong place. So the caregiver may notice that, may realize, oh my goodness, I need to clean this up and I have 20 other things to do. And so there's this conscious process of evaluating the stressor, which then may trigger an emotional reaction. However, this can also be subconscious, just the knowledge beneath the surface of awareness that the care recipient is ill, that the caregiver needs to take care of them, or the kinds of immediate reactions, for example, to a situation of aggression or another dangerous situation in which the caregiver has an immediate response, immediately feels their heart start to race, feels scared, feels angry, worried. So these evaluations are sometimes outside of conscious control, and when they occur, the fight or flight system gets triggered along with whatever emotional reaction. Stress hormones are released and their effects on the brain, the heart, the immune system. So in the process of evaluating it, for example, the caregiver may see what's going on, that those signals are transmitted to the brain, specifically to regions of the hypothalamus, which then sends messenger molecules to the pituitary, and then there's a cascade of hormones released throughout the circulation that both stimulate the secretion of further stress hormones from the adrenal glands. And then there are also direct pathways from the brain which communicate to the heart and the other vital organs with adrenaline and other stress hormones. Now, the effects can influence the functioning of cells, for example, of the immune system. And one of the ways that it can do so, which I'll come back to later when talking about some of the ways that meditation and mindfulness practices might help, is that these stress hormones, such as cortisol, have also been found to change how molecules that interact with our basic DNA function. So there are molecules in that affect our DNA that essentially serve to build up or remove what you could think of as the bumpers. Like the bumpers on a car, our DNA strands actually have bumpers on the ends of them. And these bumpers protect the DNA. They protect them from getting broken down. And what can happen when cortisol is released is that it actually affects the molecule called telomerase that's responsible for building up these structures, these bumpers on the end of our DNA, and prevent it from functioning properly, so that the bumpers get worn down and worn down and worn down. And this is actually one of the things that provides a risk of increased DNA damage over time and is associated with aging. So we'll come back to that a little bit later when we talk about the interventions. How can we help this process? So there are many different tools that people find useful, from support groups to caregiver education and training, which can occur in a one-on-one setting, skills development, family counseling, therapy and medications if it gets to that level, as well as self-help techniques and skills that the caregiver can learn to care for themselves. And so we'll be talking and focusing on meditation and mindfulness practices through the rest of this talk. And I've decided to focus on 3 that have some evidence for them. The first, mindfulness-based stress reduction. The second, a form of yogic meditation. And the third, called central meditation and imagery therapy, which I've developed here at UCLA. I'll spend a little more time on. And I'll also go over the results of some of our studies here at UCLA. So first of all, to talk about mindfulness-based stress reduction. Many of you may have heard of the term mindfulness, but what does it actually mean? So in early Buddhist thought, the word for mindfulness was sati, which actually means remembrance or recollection, a kind of presencing of mind to what's actually occurring in the moment. It involves awareness of one's own experience, including one's body, one's thoughts and emotions, but also contextualization of this experience in light of the Dhammas, or the teachings of the Buddha, including the Four Noble Truths on suffering, the hindrances that he saw on the path, factors of enlightenment. So it involved both attention, focused attention to the sensation, but also a right understanding of what this sensation was about. There was a remembrance, a mixing of these both sensory experiences along with one's understanding of them and being able to place them in the right context. Now, mindfulness-based stress reduction, which was developed by Jon Kabat-Zinn at the University of Massachusetts, aims to encourage part of that mindfulness concept. So specifically awareness, and awareness in a non-judgmental sense, that's moment by moment. So for example, being with the totality of what's occurring, gaining space between the stimulus and the response, what happens to you and what you think about it or what you do about it. So for example, someone cuts you off on the highway, the immediate reactions that you have, and what occurs before them. Mindfulness is about paying attention to that space between where you're aware of what happens and the response gets triggered in it within the mindfulness-based stress reduction program. Now, some of the things it aims to discourage are ruminating over the past, a lot of negative thoughts about the past, or evaluating what is occurring in the present moment, to the extent, for example, if you decide to watch a sunset with a friend, Kabat-Zinn says, if you're embellishing it, for example, saying that it's beautiful or then sharing that evaluation with a friend, you're no longer being mindful because you're bringing something to the moment that wasn't there initially. So as you can see, this is somewhat different from the original definition of mindfulness. I think it's important that you're aware of both so that if you do some research on your own, you're not confused by this difference. And you can also get a sense of what's being promoted within the mindfulness-based stress reduction program and how well it appeals to you and suits your personality. Components of mindfulness-based stress reduction, which is abbreviated as MBSR, include practices such as yoga, mindfulness or attention to the body and breath, really noticing one's thoughts and emotions, but in the context of the body and the breath, as well as some visual and body imagery practices. For example, imagining the sensations of the breathing, expanding and relaxing the arms, the legs, and other relaxation practices of this nature. Now, the structure of it is fairly intensive. It requires 8 weekly sessions that occur at about 2.5 hours each, and 1 retreat day, which lasts about 8 hours. And in addition, there's home meditation practice that's recommended of about 30 to 45 minutes per day. Now let's talk a little bit about the data. What's MBSR been found to do for dementia caregivers? So these are the results of one randomized controlled trial with 78 dementia caregivers who were assigned either to a community caregiver education and support intervention, which was well matched in terms of contact time, instructor contact time, to MBSR or to MBSR. And there were actually some results of this study, which was quite well controlled, favoring MBSR. So 6 months after the intervention had ended, overall mental health scores were higher in the people who'd received MBSR. Short term, so right after the 8 weeks of the intervention, perceived stress and depression were also lower in the MBSR arm than they were in the more standard support group. What was not different between groups were levels of anxiety or caregiver burden, but overall the results did seem to favor MBSR. Now I'd like to turn attention to speak about a form of yogic meditation called Kirtan Kriya, which has been studied here at UCLA predominantly by Dr. Helen Lavretsky. So Kirtan Kriya was expounded by Yogi Bhajan, who actually taught his first North American classes here in Los Angeles at the YMCA in 1969. It incorporates principles of very classical Patanjali yoga, which goes back centuries, and aims to encourage within the tradition a sense of a harmonizing of the individual mind with what he called a universal psyche, bringing total mental balance to the psyche, balancing the auric field, so there were components of mysticism within this practice. And it aimed to discourage, again, similar to MBSR, ruminative thoughts, so persistent negative thoughts that just come into your mind and intrude, as well as negative behavioral patterns. Now, applied to the clinical setting, it's a little different, so the mystical elements have been removed, and the practices themselves include repetition of a phrase, satanama, which translates, means beginning, life, death, rebirth, and is done with a melodic chanting, first aloud, then whispered, then repeated mentally in silence, along with simultaneous repetitive finger tapping, and ends with a visualization of light. Now, this is a brief practice as opposed to the MBSR practices. It's taught by an instructor in one setting, and then a person does home practice for 12 minutes per day. So a quite substantial difference in the time commitment required from MBSR as well. And there's a focus on the practical elements, not the mystical, as I was saying before, when it comes into these clinical and research settings. Here's the evidence. So one study was done with 49 dementia caregivers who were randomized to either listen to a relaxation CD for 12 minutes a day or practice this Kirtan Kriya yoga process consisting of the mantra repetition along with the finger tapping, along with the visualization of light. And the results overall favored the Kirtan Kriya practice relative to listening to the relaxation CD. So specifically, over 50% of the people receiving Kirtan Kriya exhibited a depression treatment response, which means that they felt substantially better, had more than a 50% reduction in their symptoms. In the control group, it was more in the range of 20 to 30%. Also interestingly, cognitive scores were improved in the patients receiving the Kirtan Kriya. So their mini mental status examination scores, the MMSE scores, increased over time, which we did not see in the relaxation group. And that might be due to the relatively active mental process involved with this kind of focused concentration and effort, and perhaps even an effect of the stress reduction and relaxation. And then finally, as I was saying earlier when I talked about the negative effects of caregiver stress on the body, we actually saw an increase in telomerase activity. So telomerase, again, is that enzyme, that molecule that adds the bumpers to the DNA so that they don't get, so the DNA doesn't get damaged over time. So there was actually an increase in this telomerase activity by about 40% in the caregivers who received Kirtan Kriya versus those in the relaxation arm who only had about a 3% increase. So it was really quite substantial. And this was actually correlated with a reduction in depression and improvement in mental health. So this is really the first data that shows that the negative effects of caregiver strain and stress and burden may be able to be alleviated even on a cellular level by some of these meditation practices. Now finally, I'd like to share with you a little bit about central meditation and imagery therapy, which I developed, and which aimed to be syncretic. I sat back and said, both of my parents are meditation teachers. I kind of know what that's about. I've grown up with that in my home and environment. But now I have psychiatric training as well. And that psychiatric training has given me psychoanalytic knowledge of how personality is structured. It's given me awareness of these medical and psychiatric conditions. So I'd like to create something that would be beneficial to caregivers that incorporates these different principles. So central meditation and imagery therapy, as I'll abbreviate CMIT, is quite syncretic. It draws from a number of sources. Its techniques are aimed at facilitating an integration of good and bad elements of the psyche so that a person can observe them with greater peace of mind. In this, it draws on psychoanalytic object relations theory for inspiration. It also incorporates the observing parts of mindfulness, so those parts that are involved in really paying attention to one's own experience. But it doesn't say, don't judge it. It doesn't say, focus only on the present moment. Rather, it says, recontextualize these thoughts in the context of a larger whole. Simply be aware of them and observe them in the context of that larger whole. But there's no need to make an effort to not judge or to approach it with that kind of attitude, but rather just to notice the kind of attitude in which you are approaching it. And then finally, it draws on some yogic thought from the 12th to 13th century, which emerged in the Kashmir Valley in India, which described the origins of suffering as, I think, being something that caregivers can relate to. So first of all, a sense of what they called anavamala, of individual weakness, of individual smallness, a sense of imperfection, a sense of, and then secondly, a sense of disconnection, what they called mayamala, a sense of separateness, not feeling connected to others or people in the environment or the environment itself, feeling very isolated and lonely and trapped. And then it takes advantage of these theoretical elements to promote guided meditations focused on a sense of connectedness, and even utilizes physical theories of the universe to communicate these ideas, to bring them home. How are we actually connected with others? And one of the things that we focus on are these words of Einstein that we draw on for inspiration, who said, quote, "A human being is a part of the whole, called by us universe, a part limited in time and space. He experiences himself, his thoughts and feelings, as something separated from the rest, a kind of optical delusion of his consciousness." Let me repeat that again. A kind of optical delusion of his consciousness. Those are strong words, especially to a psychiatrist. Now, the interesting thing about that is that meditators for thousands of years have described experiences of connection, of unity, of wholeness, that they've associated with feelings of happiness, with peace of mind. So what CMIT attempts to do is to bring to caregivers those kinds of experiences as well. Components include gentle stretching, guided imagery, mindfulness, imagery rehearsal or visualization where you're imagining a situation in one's mind. And the structure is 8 weekly classes, an hour and a half per class, and home practice about 30 minutes daily, so it is more on the intensive side. I'd like to share with you some results of a preliminary study that we've conducted with 12 dementia caregivers. This was not randomized. They all knew what they were getting. About 80% were Caucasian and 20% African American, so we did have a sizable minority population. And we found encouraging findings for depression, anxiety, and insomnia. So specifically, as you can see in these graphs here, levels of depression decreased from before, pre, to after the intervention, and so did levels of anxiety. And very significantly, even 3 months after the intervention had ended, those levels were still down. People's depression had not rebounded. People's levels of anxiety had not rebounded. There were some lasting effects from participating in the intervention, in some ways similar to the results that we saw with MBSR earlier. So that was encouraging. Moreover, we took an additional step of looking at people's home practice logs, what they actually said about how they felt from before they did the meditation to after they did the meditation. And what we found was that just by looking at their average scores, where they'd circle a number saying, for example, -5, I'm feeling absolutely horrible and distressed, to +5, I'm feeling really great, we could find that the average change in those scores over the first week actually predicted how their anxiety would fare over time, how satisfied they were at that 8-week marker, and overall how much benefit they derived from participating in the technique. So we didn't need to wait the 8 weeks to see who would do better and who would not. We could tell at that 1 week time point. And that's potentially promising for the future if we can replicate it in larger samples, that maybe we will be able to guide dementia caregivers relatively rapidly to see whether or not this is the kind of thing that they might benefit from. Interestingly as well, levels of mindfulness increased from before to after the intervention in facets such as acting with awareness in red, not judging oneself and one's emotions in blue, being able to observe oneself in purple. And this was the first time that changes in mindfulness had been shown in dementia caregivers. Actually, a previous study of mindfulness meditation did not show these changes in dementia caregivers. So we were fairly excited about this. I'd like to share with you additionally one case study from this that will give you a flavor of what this is like. So this was a 66-year-old married female. She'd been married for 40 years, had been the primary caregiver for her spouse with dementia for 6 of those years, and really did complain of strain and stress pertaining to her caregiving responsibilities. She also suffered from some mild depressive and anxious symptoms. And one of the things she hated, she absolutely dreaded, was helping her husband get dressed every morning. She felt like it was something that she had to do to him because he was sick. We went through the whole CMIT training process with her, and through it, the first thing she realized was that her husband was trying as hard as he could. Before she'd gone through it, she felt like he wasn't really trying somehow. She knew it was irrational, and she knew that that thought made her angry, but she just couldn't get it out of her head. But through doing CMIT, she was able to gain additional perspective. And through that additional perspective was able to actually contemplate more what was his mind like and what was the effort he was putting forth. She was able to remember that her husband and her were in it together, to generate that sense of interconnectedness with him, and even to approach it as a challenge that both of them were facing, just like any other challenge, any other of the thousands of challenges that they had faced over the course of their 40-year marriage. And she mentally rehearsed being calm and centered during the process of dressing her husband. And she was actually able to put this into practice. She said whereas previously she would experience a tension in her shoulders and her neck, even the night before, thinking about getting him dressed in the morning, this was gone. She was able to dress him with a greater sense of kindness and peace of mind, and afterwards her husband actually turned to her, this man with severe dementia at this point, and said, "You're so caring, you're so kind," and embraced her. He actually felt this difference in her. So now I'd like to briefly summarize where we've been. Caregivers, as you know, are under tremendous stress. There are all sorts of poor health outcomes, including risks of infection, even risks of early death. All three of the meditation practices I've outlined for you today can help to reduce symptoms of depression, but no one practice works perfectly. And it may be that participating in one of these that appeals to you, along with doing many other things, caregiver support groups, talking to therapists, whatever it is that you need is the right approach. Specifically related to the Kirtan Kriya practices, we find evidence for enhancing cognition and telomerase activity levels that were not present. Well, we did not study those in the other research projects. And a unique defining feature of the Kirtan Kriya practice is its efficiency, 12 minutes per day. With CMIT, one of the distinguishing features was our ability to predict benefit early in treatment, as well as these effects between the care recipient and the caregiver. And for both MBSR and CMIT, we found the benefits might last over the moderate term, although I should emphasize that the evidence was stronger for MBSR in that it was a randomized trial and it did have a larger number of subjects. Now, we often do have research studies going on at UCLA, for example, for caregivers with depression, and these are some of the places you can find out about such things if you're interested. There are websites such as depressionla.com or clinicaltrials.gov, or even the Alzheimer's Association, alz.org, has a trial match program. And also the UCLA Depression Research and Clinical Program at telephone number 310-825-3351 can let you know if there are caregiver studies related to central meditation and imagery therapy going on at UCLA at the present time. So I'd like to thank you for your attention and also thank some of the funding sources that supported this work, including the Friends of the Semel Institute, the Morris Hazen Memorial Foundation, the National Institutes of Mental Health, as well as my collaborators within the Department of Psychiatry, including Drs. Helen Lavretsky and Andrew Luchter, and my collaborators in geriatric medicine at the UCLA Alzheimer and Dementia Care Program, including Drs. David Rubin and Zaldi Tan. Thanks very much for your attention. All right. So now I'd like to address some questions that have been sent via our Twitter hashtag. So the first is, how do I know if my mindfulness practices are working? This is a great question, and it's a very frequent question, and it's one that I like to answer with a story. Okay, and the story is that a meditation student once went to their teacher and said, "Teacher, I had an absolutely horrible meditation. I just could not focus. I couldn't rest. My body was itchy. I was antsy. I could hardly even pay attention to what you were saying." And the teacher took in that student's agitated state and what had happened to them in the meditation and said, "Don't worry. This will pass. It's temporary." Now, a few weeks later, this mindfulness student, who was very persistent in her practice, went to the meditation center again, and this time had a wonderful experience. So she told the teacher, "Teacher, this was incredible. What a great, great meditation. You're brilliant. You've changed my life. This is amazing. I feel wonderful." And the teacher reflected on her good experience and her sense of excitement and said, "Don't worry, this too will pass." By which he meant these highs and lows are transitory, and we won't always have a great experience in our meditation or mindfulness practice, but it doesn't necessarily mean that we should give it up at that time. The best way to evaluate, in my view, is to look over the course of months at whether changes are being made at a deeper level. Now, specifically in regards to the central meditation and imagery therapy practices, as I said, we have a way of evaluating or predicting who's going to be better at 2 months or so, just by looking at that very first week of practice. And it has to do with how much change the person feels in their meditation in terms of a sense of some kind of movement during the meditative practice itself. But that may be specific to the CMIT intervention. It might be specific to this group of people. There are just too few subjects for us to really hang our hat on that finding at this point. But I would say it is something as well that you can pay attention to and look at it practically. Look for yourself. Really judge, is this helping me? Not as another person saying yes or no, but how do I really feel about it? Alrighty, so the next question is, how can I practice these techniques? Well, let me tell you, first of all, that 2 of the 3 techniques I spoke with you about occur in a group setting: the mindfulness-based stress reduction and the central meditation and imagery therapy. So you'd want to find a group that offers those techniques. You'd want to find an instructor that offers those techniques in a group setting, because that's what's been studied. And then you do go home and do your individual practice, but that's where it's taught. The Kirtan Kriya, on the other hand, was taught individually, one-on-one, by an instructor, and then the caregiver would go home. So that might be more feasible for some people, and instructions can be found online fairly easily for the Kirtan Kriya practice as well, but it has only been validated in that way when you do actually go through the learning process with a teacher. Alrighty, next question is, where can I find any clinical trials? And so let me just go back a few slides. So again, these websites here, depressionla.com, clinicaltrials.gov, Alzheimer's Association, alz.org can be helpful. And if you'd like to talk with a real-life person, the UCLA Depression Research and Clinical Program has this number, 310-825-3351. And I am aware of one study currently enrolling caregivers who are experiencing symptoms of depression utilizing the CMIT techniques. When should I practice mindfulness? This is another great question, so I'm going to go back to these questions here. So, and let me advance the slides so you're not too distracted by that. I'll leave it there. Mindfulness is not limited to a meditation cushion. It's something that you can practice throughout your day. And it really means paying attention and being aware of your experience, remembering what your experience is like, not just reacting in the moment. So it's something that you can practice in the morning, you can practice it at night. From my perspective, you can go meditation crazy if you want to. I think it really is helpful, especially in these settings of very severe stress. And the more that you put into it, the more that you feel better. As with anything, as with learning to ride a bike, as with juggling or any other kind of skill that you might choose to learn. Sometimes people feel like they come up against blocks, so they experience a lot of stress and they feel like the practice isn't working. But sometimes that can be a signal to go deeper, to try harder, to really take a moment to truly focus and breathe, even if it's just for 3 breaths or 5 breaths or 8 breaths, to really pay attention. Would mindfulness help the person that I'm caring for? Well, that's a very good question. So, would mindfulness help the care recipient? I would say, first of all, it depends on the stage of their illness. If their symptoms are mild and they're able to learn new skills, it might be that they could be taught mindfulness. Then the second part of that question, though, is can my mindfulness practice help my care recipient? And there are some indications that mindfulness practices, such as mindfulness meditation, can reduce a caregiver's reactivity to the kinds of things that the relative with dementia does, some of the things that annoy them or trigger them, that it can actually reduce that reactivity and bring about a calmer state of mind. As we saw with the central meditation and imagery therapy practices, that may impact the care recipient quite directly. As the person's attitude changes, as the caregiver is able to experience more calm and actually bring that into a real-life situation, it is also something that the care recipient might notice, as we saw in that case story. Where can I learn more about CMIT? So there you would want to contact us at UCLA. Our contact information can be found online or via the UCLA Depression and Clinical Research Program number. You can call that line as well. We've got another question that's just come in. Okay. Do you have plans to conduct larger scale studies with larger samples to validate your findings? Indeed, and I've been fortunate enough to receive funding from the Friends of the Semel Institute and the Morris Hazen Foundation to actively begin enrolling subjects in a clinical trial now, specifically those who are the spouses or adult children or close family members of the care recipient and who are experiencing symptoms of depression. So we do have underway larger scale randomized trials. And it is our hope to be able to follow the evidence and to really see, what works and what works for whom, because these things are not one size fits all. And that's one of the take-home messages I'd like you to get today from this. These different practices might fit into you and into your lifestyle based on your routine and what your interests are and your philosophical outlook and your predilections. I think the important one is finding one that actually works for you, one that can actually help you. So those are the questions that have come in. I appreciate your attention. Thank you very much for participating in this webinar, both sitting at home as well as providing your questions. And thank you for the work you do, especially if you are a caregiver for your relative with dementia, because it's an extremely difficult role and a very honorable one. And so we all thank you truly for your service to them as well as to our society. All righty.